Morning. How is everyone? Looks like we've got a few live already, so that's good. Just wait. Hold on. Let me just pop my comments on, and then that would make sense, and then I'll be able to see what people are saying. If you want to just drop us a message in the chat box, see if we are in the land of the living, especially after last week. Yay! Morning, Penny. Good morning. Cool. So we are live then. That's good. So yeah, we're moving on to the spine today, spinal cord, and yeah, we did a bit on the discs a few weeks ago, and this obviously ties into that quite nicely. And then, so the spine and the nerves and all that is probably going to take a couple of sessions. Good morning, morning, Becky. Yes, we've actually managed to sort everything out today. Yeah, it might take a couple of sessions, this one, and then what we're going to try and do is tie everything together, and we're going to do a session on sciatica and what causes it and the kind of symptoms people get and why they get them. But to do that, before we do that, we obviously need to understand the discs. So we've done that, and then with the spinal cord and the nerve roots and all that kind of stuff as well. That should bring it all nicely together, and then we'll be able to bring that all together. Cool. Who else have we got? Julie. I know it's Julie and not Jew. Hiya, Julie. And Tris is in the house as well. Hi, Tristan. Good to see you guys. Okay, so let's get going. So we get detailed anatomy of the spinal cord, not just anatomy of the spinal cord. We've going to have a look at the gross anatomy first, and then go down into the specific anatomy after that. Just tweak that there a little bit. There we go. Cool. So, without further ado, let's get going. So, spinal cord. Then I'm going to go over, because obviously this is for people that have never done it before as well. So apologies if you've done this kind of stuff previously. But think it's useful just to have a bit of a recap on some things anyway, sometimes, even if you've been doing it for ages. So, morning, Sarah. Morning, morning. Hello, hello. Love that picture of your dog. Brilliant. So I'm fingers crossed. My wife's away at the moment, and usually she works at home on a Monday and looks after the dogs and makes sure that they behave themselves. Yeah, I'm hoping that they'll be okay. But if you hear some barking, then there's nothing I can do. Vertebral column then. So we've had a look at this over the last few weeks, and we've looked at the bony anatomy, looked at the ligaments, we've looked at the muscles that surround everything, and now we're going to have a look at the way all of that is controlled. So looking at the spinal cord and the nerves that come off the spinal cord, how they come off it, how they then join together, where they then go, and then we'll do a whole section on probably next week on the lumbar plexus. As I feel that we need to kind of cover this stuff first. But just a bit of a recap. So obviously the vertebrae are stacked on top of each other. There's vertebral foramen down the center of the spinal cord to protect the spinal cord, and we'll have a look at that in a second. We've also had a look at it previously. There are intervertebral foramen on the sides of each level. So this is where the nerves will come out. They'll emerge from there. So centrally, you've got that vertebral foramen. A foramen just means a hole or a gap, and on the sides is the intervertebral foramen. So where the pedicles are on a vertebra, above and below, so the one above and one below, it's there that the nerve root emerges, and that we covered a few weeks ago now. We did a whole session on the anatomy of the vertebra. So this is where the peripheral nerve emerges from, and then obviously we've covered the sacrum and the coccyx, and now we've moved up into the lumbars, and then we'll go up into the thoracics as well. But we've got 5 lumbar vertebrae usually, and again we've had a look at the anomalies there, where sometimes there's a sacralized lumbar or a lumbarized sacrum, And interestingly, I had somebody contact me with who has a patient who had that on X-ray, and they felt that their movement was a bit restricted in the lower back. Yeah, and that's what it showed on X-ray. So it's quite interesting. They do happen in real life. So this is something that you probably have heard before, and might not have put kind of two and two together. So we've got something that wraps around your spinal cord, and there are several layers that wrap around, and it's all connective tissue, and we'll have a look at it in a second. And it's uh, you've probably heard of the condition meningitis, and meningitis is an inflammation of the meninges. Okay, so we've got these meningeal layers that are protective layers that wrap around the spinal cord itself. So the meninges, which we'll have a look at in a second, is made up of these three layers. They're dura mater, which is tough mother, like durable, arachnoid mater, spider mother. So this looks, and you'll see it in a second, it looks like a bit of a spider's web. Okay, so like a, you know, those ones that are really wispy. I really hate spiders, and I've had to find some pictures of spiders' webs to put on the videos later. And yeah, in fact, just thinking about them now is just making my skin crawl a little bit. But yeah, I'll show you the kind of image that they look like. And then Pia Mater means delicate mother. So we've got these three layers that all wrap around and basically hug the spinal cord, and that's why they're called mother, because it's like a mother's hug. That's the story of where they came from. So we've got a tough mother, a spider mother, and then a delicate mother. Okay, so and they're all obviously different consistencies, if you like, of connective tissue. They wrap around the spinal cord. Okay, yep, there we go, like a mother's protective cuddle, but they're also continuous around the brain. So as they come all the way up the spinal cord, they also then wrap around the brain, and you have meningeal layers around the brain as well. So if we have a look at this image here, so you've got an aponeurosis, so a flat tendon. Then you've got the bone, so this is in the skull, and that, well, periosteum first, then the bone, and then you've got the layers of the meninges. So these are just underneath your skull, and they'll wrap around the brain and then envelop the spinal cord all the way down. Okay, and this is one of the reasons why meningitis is so dangerous, is because it has access to your whole nervous system, and if obviously if there's an infection in there, then it can just spread. So we've got the dura mater, which is the outer covering, the outer layer. Then the then the arachnoid layer, and then the pia is actually around the like attached to the brain and the spinal cord, so it's the physical attachment. So yeah, those are your layers, and like I say, they're all the way down the spinal cord. So let's have a look at that first of all. Just get rid. Yeah, I think this is it. I'll just get rid of that ticker along the bottom. So quick recap on the structure. So there's your vertebral foramen. So that's the hole in the middle, and then in a second we'll see the intervertebral foramen, but it's not the focus of this video, so we'll have a look at that in a sec. Transverse processes, we should know those by now. This looks like a thoracic vertebra just because of the shape, and you've got some nodules on the side here where the ribs attach. They look, and they're kind of shaped like a thoracic. And then spinous process here. Obviously, it's exactly the same setup in the lumbar spine. But just the vertebral bodies are a bit thicker. So let's have a look at this. Okay, so there is the spine with your like a cross section with the spinal cord left in. Okay, so vertebral body at the front, and then you can see this gap around your spinal cord, and that's the cord there just in the middle. And there it is. Okay, so I'm just going to pause that there. So I've just brought in some other pictures as well. So you might have seen this picture before, cross-sectional picture of a spinal cord. And you've got the grey matter, which looks like a butterfly in the middle, and then the white matter around the outside. And you can just about make it out in this video as well. So you can see in the middle there is a bit grey, and then around the outside here is more white. Okay, it's the density of the neurons that give it that color. Okay, so where there's lots of connections and lots of interneurons all crossing over each other, the density of the neurons give it a different color. All right, so that's where they come from. So there's the room behind, and you can see these little rootlets coming off of the side of the spinal cord, either side there. So I'm just going to pause that there as well. So we've got what we call ventral nerves, and ventral is towards the front. So we can see the vertebral body just here. So those nerves come off the front of the spinal cord, and then dorsal nerves. Dorsal is posterior, so I've popped a picture there of the dorsal fin. So if you think about dorsal fin like on a dolphin, it's on their back. So dorsal is posterior just there. So we've got dorsal or posterior nerve roots, and then ventral or anterior nerve roots. So in the spine, they're given different names for exactly the same thing. It's not an anterior nerve and a posterior nerve, although you could say that, but it's usually called ventral and dorsal, okay, just because of what it is. And I agree, Becky, it is pretty cool. That it gets cooler. So we're going to have a look at these layers now. So there's the first layer. So that's the connect. I'm just going to move me up here. So that's a piece of connective tissue, just all around there. And hopefully this will make sense with what we were talking about before. So that is your dura. Okay, so dura mater, which is durable, okay, or tough, and it's part one of your meningeal layers. So all of that there, all around there, that is your dura. Okay, and you'll see that the dura, so where those little rootlets come out, they then form the nerve roots, which we'll see in a second, and the nerve roots are covered in the dura, so everything's sealed. Okay, and you'll see that in a second. And then just on the inside, that layer there, okay, this is where I had to search up freaky spider pictures. Arachnoid layer, and you can see it looks like a spider's web. Okay, yeah, but spider-like, basically arachnoid. So spider mother wrapping around. So we've got this really thin layer, wispy kind of layer on the inside of the dura. All right, so that's another part of the of your meninges. So dura, then arachnoid, and then you'll see. So this space all around here, obviously this is not normally empty. This is usually filled with fluid. Okay, we'll have a look at that in a second. And then this is really attached to the spinal cord itself, and that's the pia. Okay, so the delicate or tender mother. So this wraps all the way around the spinal cord. So we've got these three wrappings all around to protect the spinal cord. So yeah, this layer here, the subarachnoid layer. So subarachnoid just basically means underneath the arachnoid, and this is usually filled with CSF, which is cerebrospinal fluid. So I've just popped a little picture on there. You can see it all the way around. So if you have ever heard of someone having a skull fracture, my wife is someone who's had a skull fracture. She's fine. I can laugh about it now. But she had what they thought was a base of skull fracture. So just got kind of right up behind her nose, and she was having a CSF fluid leak from her nose, and it was dripping out her nose. So yeah, that's where it comes from. I can testify if you have any problems with the CSF pressure, drop in pressure or increase in pressure, you get banging headaches. Okay, and it's something that should be investigated with some urgency, which it was. Okay, so yeah, so that is CSF, cerebrospinal fluid. So it basically covers your cerebral space, so around the brain, and all of the spinal cord as well. Okay, I always used to think it was quite viscous, and because used to teach first aid training, well, I still do a bit, and talking about head injuries and that kind of thing. And we always used to say CSF, if you remember it, like clear sticky fluid, but it's not sticky. It's like so apologies whoever I taught years ago. I now know after seeing it, it's like the purest water you have ever seen, like something coming out of a fresh stream. Yeah, it is so clear, but it's really quite it's really quite uh, like I don't know, like a really fine liquid. So it's not sticky at all. It's not like that at all. But yeah, so that fills all of that space. So obviously with things like that, like a skull fracture, and kids with ear infections as well, that they're at risk of then potentially getting meningitis as well, because the ear is a way that you can get into that whole system. Taste, it tastes salty. I didn't taste it. That's what she said. Okay, so it did taste salty. Yeah. So yeah, it's very interesting. Having taught about it for ages, actually seeing it. So that was it was a useful experience for me. But yeah, so if you get an infection there, obviously from a skull fracture, there's a severe risk of meningitis. So she had to have a vaccine against meningitis after that injury. So yeah, and so like I say, bangs on the head with kids. You've got to watch for CSF leak coming out of the ears and the nose. Those are areas where they can usually escape from. So and in fact, just a little aside, like I said, I've been teaching first aid for years, probably over 20 years, and I teach a lot for the schools around me, and all the lunchtime supervisors. And I did a course at a school where a kid, after the course, had fallen over, hit their head, and the lunchtime supervisor noticed some fluid coming out of the kid's ear, and sent him off to A&E. And yeah, she said if it wasn't for the course, then she wouldn't have noticed, and God knows what would have happened to that child. But they turned out that they got everything sorted in time. So you can spot these kind of things if you know what you're looking for, basically. So yeah, CSF can leak out of nose and ears if you have head injuries. So there you go. So that's under the subarachnoid space. And then those of you that have had children or lower back pain may have heard of this one. This is the epidural space. So epidural means upon the dura. So where the dural covering is around the outside, that's where they will go in for an epidural. Okay, so you hopefully just about see there. It's going in through the interspinous ligament, so in between the spinous processes, and then towards the spine itself. Okay, and they'll do it in the cauda equina area, because if it does go through the dura, then you won't hit anything, basically. But that's something we need to talk about in a sec, so I'll leave that for a second. Okay, so that's your subarachnoid space, and then epidural space as well. Okay, so that's what your spinal cord looks like when it's in the body. Cool. So yeah, so this is a little bit of a breakdown of it. So we've got the dura, which is the most superficial. It's continuous with, just move me there, with the brain dura, and attached to the outer of the spinal cord. Okay, so it's all around here, and then you can see these. So this is the dura that's been peeled back here. This is a good image. So there's the arachnoid, and then there's the nerve root just coming out there. Okay, and you can see how the arachnoid and the dura cover the nerve root as it comes away from the spinal cord. Okay, these are all little rootlets. Okay, and if they're at the back, they're the dorsal roots. If they're at the front, then they're the ventral roots. Okay, and these all join together to form a root. Okay, so you've got rootlets and then forming a root. So on this particular picture, this is the dorsal root. and then the spinal cord in the middle there. Okay, so you'll have exactly the same kind of thing coming off the front as well, and those will be the ventral roots. Right, so the arachnoid layer is the middle meningeal layer, looks like a spider's web, and between the dura and the arachnoid is some interstitial fluid. So interstitial means in between tissue. So we've got another layer of fluid within there as well. And then the innermost layer and the thinnest layer is the pia, which physically wraps around the spinal cord itself. It contains the blood supply for the cord, and it joins with the arachnoid and the dura to form something called denticulate ligaments, which we'll have a look at in a sec. But those are these just here. Okay, so for the cord to be able to stay in place, there are a few firm attachments to keep it in position. Otherwise, it would just wobble about all over the place. So there's a ligament that attaches onto the bottom, and then there are these that attach onto the dura all the way along to keep it in position. So yeah, the space between the arachnoid and the pia contains the cerebrospinal fluid, which is what we've just seen. Cool. So I think that's just another picture of the same thing. Yeah. So that's just a still image of the video that we've seen. So the spinal cord, dura around the outside, and this is a nice one because you can see the rootlets coming off, forming the roots, and then joining together and coming out here. Okay, so there's your vertebral body, and that will be a transverse process and a intervertebral foramen. Okay, what you'll notice as well on the dorsum of the spinal cord, with the rootlets that are coming off there, when they form a root, they form this little bulb. Okay, and that's called a dorsal root ganglion. So the DRG, the dorsal root ganglion, is a thickening of the nerves coming out of the back, so the dorsal part of the spine, and they're significant. We'll talk about those in a second. I don't want to, people who've never done any of this before, I don't want to blow your heads off with too much information. Okay, we'll do it little by little. So yeah, basically, if you might have heard of a ganglion cyst. So a ganglion cyst is where there's an increase in fluid, usually in a joint space, and then it just pops out of the joint, and you've got like this bulb. Okay, and usually it's on the wrist. You can get cysts behind your knee called a popliteal cyst. And yeah, basically it's the synovial capsule that is bulged out. Okay, so that's a ganglion as well. So that's basically what, and this isn't cyst like, this is full of nerve endings or nervous tissue rather than nerve endings. So, and it's because there's such a density of those nerves, it's created a swelling. Okay, and that's the dorsal root ganglion. Okay, so this is where things get a bit interesting, because we've got your cord doesn't go all the way down to the bottom of your spine. Again, you may or may not have heard this before, but your spinal cord actually finishes here, which is around the level of L1. Okay, so around about L1, L2. So in newborn infants, the cord fills the vertebral column, so it goes all the way down to the sacrum. But as you grow and as you develop, the bones around the cord will grow, but the spinal cord stays roughly about the same size. Okay, and what happens is the nerves that attach to your legs, they get stretched as you grow. So your cord stays roughly the same length. These nerves coming off will get stretched. So what's left down the bottom here is a collection of very, very long nerves that have all been elongated as you've grown. Okay, and that this is what happens during embryology, and we will talk about that next week a little bit more. So you're basically like a sausage when you're an embryo, with little buds for arms and legs. Okay, and then as you grow and as your arms pull out and grow, the nerves get stretched along the arms. Okay, so when you this is why corresponding parts of your neck will provide sensation and power for corresponding parts of your arms or your legs. is because the nerves were next to your spine and short, and then as your legs and your arms grew, they all got stretched. Okay, so this really helps when you're doing neurological testing, because you can work out roughly where the problems are. It's not very accurate, but you can work out roughly where they are, or if if there is a problem, based on the presentation when they're coming into clinic. Okay, so yeah, it's useful for, sometimes useful for diagnostics. They often not very accurate. Like I say, there's a bit of a crossover. I agree with you, Penny. It is fascinating. Yeah, definitely. So, but this is why they go the epidural down here, because if they went up here, you'd hit the cord. Whereas down here, if you go through the dura, then the nerves will just move out the way as the needle goes in, and you won't injure anything. Okay, so if you imagine like loads and loads of like hair, and you kind of pushing through, and it will just push through one of the segments, so it won't pierce anything. Yeah. Whereas if it was in the cord, it was just solid, then it would hit the cord. So that's why they do epidurals where they do. So elongation of the cord stops at the age of 4 to 5. Okay, so and the cord finishes at something called the conus medullaris, or the conus medulla, and that's this section here. And what you'll see on an MRI scan, if you've ever had one done or you've received a report, it will make a comment about the conus and whether the conus is in a normal position. And that's, I've never seen it abnormal, to be honest, so I don't know what the report would say if not. But yeah, it usually says conus lying in a normal position, or at the level of L1, which is what you'd expect. Okay, and then you've got this, the filum terminale. This arises from the conus, so the end of the spinal cord, and it attaches to your coccyx, and it basically anchors your cord in position. So it's like a thin ligament that goes from the end of the cord all the way down to your coccyx. Okay, so this is why if you land on your bum and you fracture your coccyx, why it can be so painful, because what it can do is injure that ligament, and then your cord is then no longer fixed in position. Yeah, so it does then have room to move. And again, I don't know how uncomfortable that would be, but I can imagine that it wouldn't be very nice. Okay, so yeah, that landing on your bum and fracturing your coccyx might sound funny, but actually it could be really sore. Okay, so spinal nerves, gross anatomy. Again, we've covered some of these. So we've got spinal nerves are the communication lines between the spinal cord and then specific regions of your body. So you've got nerves that are coming, or neurons that are coming into the spinal cord and giving information to the brain, and then the brain is then interpreting that information and then sending messages out along another set of nerve pathways to create some kind of action, okay? Whether it's on the muscles or glands or whatever it is. Okay, so we have 31 pairs of spinal nerves, and we've had a look at the sacral nerves and the coccygeal nerves on the sacral plexus. We're going to be focusing on the 5 pair of lumbar nerves, okay, for over the next couple of weeks. But obviously we've got additional nerves in the cervicals and in the thoracics, and we've also got cranial nerves, okay, and that's a whole session on its own. So 12 pairs of thoracic nerves, 8 pairs of cervical nerves, but we're going to be focusing on these, okay, these 5 pairs of lumbar nerves, and we'll do a kind of overview this week, and then we'll go into the lumbar plexus in the following weeks. Okay, so what have we got? We have got 2 big bundles of axons, which are called roots. Okay, so that you can't see the image very well, but the spinal cord will be here. This will be the dorsal root, so the one at the back, and this is the ventral root, the one at the front. Okay, I've got a better picture in a minute. I'll show you in a sec. So anterior or ventral, which is what we've seen earlier, and then posterior or dorsal, so the one at the back, the dorsal fin. Okay, they connect each spinal nerve to smaller rootlets, okay, which are smaller bundles of axons. So that's the bit that connects to the spinal cord. So you've got rootlets coming off of the cord, and then they all then come together to form a root. Yeah, so that's what they are. So these rootlets join the spinal nerve to the spinal cord, and the posterior roots and the rootlets contain only sensory axons. So an axon is like the messaging part of a neuron. Okay, so at the dorsal aspect, so the rootlets and the roots that come off the back of your spine, that is sensory. So the sensation of your body. So that is information coming from the outside, so from your skin, from your joints, from your organs, all coming back in to the back of the spine. So that's where it gets its information from. Okay, and then you've got this dorsal root ganglion, which is a kind of increased density of sensory neurons just before it goes back into the spinal cord, and we'll talk more about that next week. Okay, and the importance of that. So the anterior roots and the rootlets, they contain only motor axons. Okay, so these ones at the front are motor, these ones at the back are sensory. Okay, and they provide nerve impulses to muscles and glands. So whatever sensory information is coming in and then interpreted by the brain or a reflex action, whatever it is, then the motor neuron is then activated, and then something happens, either a secretion of a hormone or a movement of a limb. Okay, whatever it's attached to. Okay, so that in essence is in its simplest form is what a nerve root is. So this is probably the picture that you might have seen previously. So we've got the axon of sensory neurons. So this is the dorsum, and we know that it's the dorsal root because of this. Okay, so this is the dorsal root ganglion, so the collection of those sensory nerves. We've got the cell body of the sensory neuron in there, so that's talking to the sensory nerves that are coming in from the body. Okay, so we've got impulse coming in here and then relayed into the spinal cord. And then we've got this purple thing here. So that is called an interneuron. So this is basically an in-between neuron. Okay, so this will either communicate with a neuron at the same level, or it can be levels up or levels down and spread, and or maybe even several. Okay, so this is why the sensation, the color of this area is different to the outside because of the density of the interneurons that are interacting with each other. That's a really good question. Yeah. So what about articular branches, dorsal or ventral? So when they get to that stage, articular branches are usually sensory, but I'll talk about that in a sec. Okay, that's good. So then we've got this. So imagine here. So we've got a sensation coming in. So you've stepped on a pin, sent to the cell body in the dorsal root ganglion, into the spinal cord, activating an interneuron that then activates a motor neuron to tell your hip flexor to contract, to lift your leg away from whatever it is you've stepped on. Okay, so that is a classic kind of reflex action. It's not as simple as that. There are some other things that are going on as well. You will also get a message that is sent to the brain to let your brain know what's going on. And there are all sorts of weird and wonderful things that can happen if there is a problem with your brain or your spinal cord. But we'll go simple for now. So if we think about this, this is the bit that comes out of the spinal column. Okay, and that bit there is a mixture of both sensory and motor nerves. So when it comes out of the spinal cord and out of the spinal column, so in those intervertebral foramen on the side, it is then a mixed nerve. Okay, and it will be a mixture of both sensory and motor nerves coming out. So that will go some way in a second, Sarah, to explain what goes on with the articular branches as well. Cool. So this is really important, the cauda equina. You may have heard of something called cauda equina syndrome, and we'll have a look at this in a second. So, yeah, in the infant, the cord fills L3, L4, and then the spinal nerves exit through the adjacent intervertebral foramen, but it gets stretched as you develop. And then in the adult, the conus usually lies at the level of L1, L2. So that's what we were talking about before. So there's the conus just there. This means that the lower nerves, the lumbar, sacral, and coccygeal nerves, get stretched and they form the cauda equina. So cauda equina is basically horse's tail. So let's have a look at that. Okay, this one. Thankfully, all my videos are working today. Okay, so they're going to remove the lamina and the spinous processes from the back. And basically, this is what it will... pipe cleaners at the ready. Yeah, that'll be next week. Yeah, order them. Hobbycraft. Yeah, quick. I should get shares in Hobbycraft. So there's your spinal cord. Okay, all the way along there. And we've had a look at the sacrum already. And basically what they've done is they've taken off the spinous processes, yeah, and gone down the lamina so we can see the cord itself. Okay, this video is by far one of my favourite videos of all time. Okay, base of skull. Who needs Top Gun? Okay, so there is the dura. Okay, so the spinous process has been removed. Remember, we've got that dural sac that covers all the way around. So we saw it from a top-down view before, so this is a slightly different view. So there's your dura. Okay, there's the base of the skull. So the dura is continuous with the brain. Yeah, so it comes up through there. That's called your foramen magnum, which basically means big hole. So this is what the image that we saw before. Yeah, so these are all the different layers. So you've got the bone layer and then your meningeal layer. So the dura, arachnoid, and pia, and that will be continuous underneath that skull. Yeah. This just to let you know is where you might have heard of something called a Chiari malformation. It's I say it's common. It's not common. It's a problem with EDS sufferers. So for Ehlers-Danlos syndrome. So if you have a connective tissue disorder, then the ligaments that support the foramen magnum and keep the brain in position are lax. So basically, your brain drops through the foramen magnum, and that is a Chiari malformation. Okay, so just a bit of I don't know where that came into my head or why, but there we go. So foramen magnum, big hole. There's your sacrum, and we've had a look at that before. So these are all the sacral roots, and the filum terminale will be in there as well. So that's that ligament that attaches your cord to your coccyx. So going to have a little bit of a zoom into the cord. So what they've done, they've cut down the dura and then they pulled it back. So this is what the cord looks like in real life. Mental. And you can just see the rootlets at the back there. Okay, so those are your nerve roots. That's what they look like. And you can see them just emerging through that dura. There's the pia. There's the denticulate ligaments, so tooth-like ligaments, and they do look like kind of fangs. So this is in the, by the looks of it, in the cervical region, yeah. So cervical spine, and the orientation of the nerves are in an obliquely downward position. So see the little rootlets just there. So these are the dorsal roots, the ones at the back, and then those are the ventral roots, the ones at the front, just there. Okay, so they're anterior just there. Okay, it is just amazing. So these are the direction of the roots in the neck. So they go in a kind of obliquely downward fashion, and you can see those little rootlets all there. This is the thoracics, so the direction is more steep in the thoracics. And then when you get to the lumbars, they're vertical. Yeah, because of the cauda equina, and there's the conus just there. So that's the bottom of the spinal cord. So that'll be about L1, L2 around there. That's the conus. So the end of the cord, and this is the cauda equina. This is what it looks like. So it is literally like a horse's tail. Thankfully, it doesn't look like a spider's web. Okay, so that, and then you can see the nerves coming through. Okay, so these are some of the ones that we've looked at before when we looked at the sacral plexus. That's them coming through there. So they will be a mix of sensory and motor nerves that come through those areas just there. Okay, it's amazing that. Love that video. Okay, so just something to be aware of. There is something called cauda equina syndrome, and again, you might have heard of this. So the cauda equina is formed by nerve roots distal to the level of the spinal cord termination, so beyond where it stops, so the conus level at L1, L2. The cauda equina syndrome is caused by compression of these nerves, so the nerves that are in that space below L1, L2. Yeah, so the compression can occur by several different reasons. So it can be a trauma. You might have a car accident. You might have a fall off a horse or something like that. You might have a fracture or a displacement, something like a spondylolisthesis, where the vertebra has slipped. Okay, so anything like that. Or there could be a tumour, or a metastatic deposit, so where the tumour is, we call it metastasized, where it's spread around the body, and then it can latch itself in that region and then grow. And of course, because there's not much room there, as a tumour grows, it then compresses the nerves. So that's when you have cauda equina. So cauda equina it isn't just about cancer. There are a number of other reasons why you would get cauda equina syndrome. Because permanent neurological damage can occur, the early identification and urgent treatment is really critical. So what we put together in my clinic is this. So we do what's called a safety net, and we safety net people. So if somebody doesn't have all of these symptoms, but you think they might be likely to develop them, you can give them this card as a warning and say, look, if these symptoms, so any of these symptoms, you get these, then take this card with you to A&E and tell them about your symptoms, because you need to be checked quickly. Okay, and they can be things that you don't often think about with back pain. All right, so just you can screenshot that and have a look. It's based on a card that was given out by a group who did a paper about cauda equina and spotting it early in clinic. Okay, so that's that. Metastatic cord compression, so where you have spinal tumours. These are that there was something. So Sue Greenall, who's written this article, she said that when she looked over the literature, there were 200 symptoms and signs for cauda equina syndrome. So they are metastatic cord compression. So we needed to get something simpler to and see what the most common signs and symptoms were, and it was these. Okay, so again, not just going to read these out. You can screenshot this and have a look at it. But these are the things that would indicate, Jesus, they might have something really seriously wrong. And one of the things I'll just highlight, just so it doesn't scare the bejesus out of you, but sleep grossly disturbed due to pain being worse at night. So there was a comment made on one of the Facebook pages the other day, and there were so many red flags in the comment, and there wasn't even one mention of sending that person to A&E, night pain linking with cancer. Yeah, gait disturbances. So you're going to have gait disturbances because of the effects on the nerves that are coming through that region. Okay, things just feel different. I've had a patient who's had this, and things feel different. You get normal back pain. You've had it before, and you kind of feel, yes, it will ease off after a little bit if I move around. This does not change. So if you have a tumor in your spine, then it doesn't matter what position you get into, you can't get rid of the pain, right? Because it is there. So things like that, and this was the thing with the post that was done the other day. They were trying all these different treatments and nothing was working, and you're like, that's a red flag. Yeah, big time. So you just got to be mindful of these kind of things. Sometimes it's not just about back. This kind of thing is very, very rare. So it's less than 1%. but it's you want to try and catch those 1%. Cool. Okay, where are we at? 45. Okay, let's just show you one last video, and then I'll cover this on the next week. Today's just gone flying by. Okay, right. Oh, this is a good one as well. Okay, remove the spinous processes again. Yeah, that's exactly it. Yeah, and I think that's the thing. It's one of those where you don't know if you don't know, and when you know, you're like, Jesus, quick, get them off. Also had a patient with this. Yeah, it's awful. Yeah, it's not nice, and it's horrible telling them you need to go to A&E now. You know that it's not nice to have that conversation. You say, look, I don't want to scare you, but this could be something not very nice. So you need to go to A&E to get it checked out. And then of course they ask what they think, what you think it could be, so you have to tell them. Okay. Yep. Yeah, it's there's a really good paper. It was a little while ago now, about 2012, and it gave all of the likelihoods of lower back pain and metastatic cord compression and cancerous tumors basically are usually less than 1%. 95% of things are things that are fine, and there'll be no problem at all. It's those top 5%, and especially that top 1% that we need to be concerned about. So usually it's nothing to worry about, but sometimes it could be, and that's where looking for those symptoms and understanding the anatomy and why they would get it. It makes sense. Yeah, it makes sense why they would have it. Cool. So this is a really good video. Look at those little rootlets there. You can see those there. So this is obviously towards the back that you can. So the back looking in. So these are going to be the dorsal roots, and with the ventral roots at the front. So we're going to have a look now at where these come through, and then we're done for this week. So that's where they're coming through there. So there's your vertebral body. That's the intervertebral foramen, and then there's the nerve coming through. Okay. So there's the holes. Facet joint's just there, so we're going to take a facet joint away. End of the pedicle, and there you go. Look at that. Okay, so there's the dorsal root, there's the ventral root, and then that's the dura. And you can see how it attaches to the nerves as they emerge. So when they're here, they're mixed. Yeah, so as they're coming out of here, they're mixed nerves. So you've got the dorsal root ganglion, which is basically a bunch of sensory neurons. And then as they emerge out of here, that is a mixed nerve. And we've got two little branches. Here we go. So there's the anterior, there's the anterior branch, and then there's the posterior one. So those there, that posterior ramus, that supplies the skin and the muscles on the back. And then these ones, oh, there you go, posterior is sensation and motor for muscles directly on the posterior spine. And then these ones here, these do the rest of the body. So the sensory and motor for the rest of the body. Yeah, so there's a little branch that comes off, a mixed branch that supplies the skin and the muscles on the back. And then that branch there is a mixed one again, so sensory and motor, that go to the arms and legs and organs. Okay, cool. There you go. So that's a intro to the spinal cord, the nerve roots, and we're going to build on that. So we're going to have a look at the detailed anatomy of the spinal cord, have a look at the grey and the white matter, and we're going to also have a look at something called tracts. So TRACTS, tracts. So if you want to do a little bit of homework before next Monday, then you can, because it's pretty heavy. But hopefully, with the layers that we've put on, then you should be able to make sense of what's going on. Yeah, cool. First one done, and yeah, it might be 2 or 3 weeks. This one, we'll see how we go. So yeah, we'll add on next week. Any questions about today, then just pop them in the chat and in the Facebook group. And yeah, if you've got any questions, hopefully we'll be able to answer some about the articular branches as well, and it will all become a bit clearer as things start to come together. Okay, cool. You're welcome. Thanks, Becky. See you later.